So the question is, so I have nothing to disclose, unfortunately, and the question is, should we, not whether we should use VNS in epilepsy and depression, because I would say yes, we should, but preferentially and early. And I am saying no preferentially and not early. And this will my debate bit about. So, vagal nerve stimulation has been approved by FDA for treatment of epilepsy and treatment-resistant depression. What is treatment-resistant depression? This is, in the literature, it is a major depressive disorder. Actually, vagus nerve stimulation in epilepsy is indicated in patients in whom resection is contraindicated or failed. So it is a late treatment of epilepsy in patients where the curative therapy is not possible. Regarding the link between depression and epilepsy, actually the first ideas regarding use of vagal nerve stimulation in depression were based on the antidepressive effect of some antiepileptic drugs like carbamazepine, valproate, lamotrigine, and so on. And so the idea arose that VNS can be a potential adjunctive treatment for major depressive disorder. So there were a series of papers regarding depression. Here I just took the last one, summarizing the fact that the VNS has superior outcomes in effectiveness and mortality over a long-term period compared with treatment as usual in major depression. Yes, we saw already some papers here that VNS is associated with mood improvements in patients with epilepsy. The first paper was by Gerta Elger showing some mood improvement 6 months after the implantation, independent of effects on seizure activity. And this is a constant. I will show it later on that there is no link between control of seizures and the influence on mood and quality of life in patients with epilepsy. But in this, as well as in other studies, the patients didn't meet necessarily the criteria for clinical depression. They improved mood, but they were very often not depressed. And I'm afraid what I saw from this Croatian study that the patients were not necessarily depressed. This was a general treatment-resistant epilepsy population. So they improved mood. And here is this recent study you showed already from 2011. The same, again, quality of life and mood was improved independent of seizure control. So it indicates an additional antidepressant effect of VNS, but it was, I'm not sure that it is an antidepressant effect. It's a mood improving effect. And of course, we would need much more and much better focused studies to show what exactly happens with patients depressed in epilepsy. So why not preferentially and why not early? VNS is established methods in a major depressive disorder, but the depression in epilepsy is different. Integral dysphoric disorder is not the same as major depressive disorder. Potential mechanism of actions in epilepsy in major partly share, as it was showed already by Mike, but they differ also partly. We have other options, non-invasive treatment of depression that should be considered first. It is well possible that VNS has a placebo effect, at least partially explaining its effect on the mood. Why not early? Because the early effects of VNS are not as good as the later one. It takes time. So we need to treat acutely a situation. We have a depressed patient, if we want to treat him now, so we will gain the optimal effect in 1 to 3 years. And finally, Adverse effects were discussed already, and the price. So point one, depression in epilepsy is not major depression. The around up to 50% of epileptic patients are depressed, but not with major depression. Interictal dysphoric disorder, that means it's depression in epilepsy, has features overlapping with major depressions like depressed mood and so on, but also other signs. It is fluctuating disorder with irritability sometimes, anhedonia, helplessness, anxiety, and so on. So it's not the major depressive disorder. It can share some features, but it differs also. It was shown that it is very much dependent on psychosocial factors and on seizure control. It was the Greek study from 2015 showed that unemployment was a major factor in depression in epilepsy. People with epilepsy have often depressions which can be the result of seizures, anti-epileptic, or influenced by the fact that they have seizures, anti-epileptic drugs, and social demographic factors. So we need much better to understand the depression in epilepsy. So regarding mechanism, it was very nicely shown by Mike Sperling that there share a series of mechanisms that could be influenced the epilepsy as well as depression. But when we look at for example, in the PET study, in the activation of regions in depression, it is subgenual cingulate cortex, hippocampus, insula, amygdala, temporal parietal responses that are important for depression, but not necessarily important for patients with epilepsy, and vice versa. We have much widespread cortical improvement, influence on cortex that is important for VNS and not necessarily for depression. Yes, as was shown already, that it is nucleostactus solitarius, that is a common pathway, but then it is for depression, it is important that locus ceruleus and Raphael nuclei with noradrenergic and serotonin system are influenced, but it is not necessarily the case in primary generalized epilepsies, in Lennox-Gastaut syndrome, and so on. Okay, I can skip that because it was declared already, explained. So regarding one slide regarding other options. Before we think to go for an invasive treatment, we should consider non-invasive options for treating epilepsy. First, we have to look at the pharmacotherapy. We know that certain drugs may have negative psychotropic properties, may have negative effect on depression, like felbamate, levetiracetam, phenobarbital, primidone, topiramate, zonisamide, and so on. So perhaps removal of these drugs, replacing by other drugs with positive effect, like valproate or carbamazepine, would be helpful. Of course, we shouldn't forget the psychotherapy. For example, in Parkinson's disease, it appears that the best treatment for depression is psychotherapy and not drug therapy. We don't know, I am not aware of such studies in epilepsy, but we should consider that. And then we have also drugs, and I agree with Mike that there are many problems with antidepressant drugs, but still, I have patients who are doing better, or I don't know whether it is the result of the drug, but simply depression in epilepsy is fluctuating. It is not a stable depression like in major depressive disorder. Yes, and now I am going to the possible placebo effect of VNS on depression in epilepsy. It was shown that 80% of patients expressed satisfaction with VNS therapy, but there was no statistical difference in the psychosocial metrics before and after VNS, irrespective of the seizure control. So responders to VNS exhibited remarkable improvement in most aspects of quality of life. However, significant quality of life improvement were also seen in patients considered non-responders. So this raises the issue of placebo effects potentially associated with anti-epileptic effect and possibly also with antidepressant effect. And here we see trigeminal nerve stimulation, so another stimulation techniques. And again, we see here an improvement of quality of life and back depression inventory scale. So again, some non-specific improvement of mood and antidepressive effect and improvement of quality of life in other neurostimulation technique, completely different. Then, so the next step is my argument against the early implantation. Here's our study, 100 patients followed. Here, in the first year after the implantation of VNS, we see the efficacy on seizures around 45%. In the fifth year, 65%, but it takes time. So it is an argument against the early implantation in depression. And it was shown also that the efficacy in depression is also appears to be gradual, and some short-term studies were unsuccessful because the antidepressant effects is also not in the very beginning of the after the implantation there. Here are some quality of life 3 months and 12 months after implantation. You see an increase already, that the increase of quality of life is gradual. Finally, adverse effect. I agree with Mike that it is something that is usually we can master with adjustment of the dose, but after 1 year, still we have cough, voice alteration, dyspnea, and so on. And I don't know whether the adjustment of the dosage, what does it do with antidepressant effect? And finally, a perspective could be in the future, the non-invasive stimulation. It will be easier. We can start and stop it very quickly. So to the end, palliative treatment comes after the end of the long series of investigation of the pre-surgical evaluation. So it can't be actually applied early. So should we preferentially use VNS early? No. Yes, we should use VNS in patients with both seizures and depression, yes, but not preferentially and not early. So please vote no. And in the end, I would like to invite you to the Epilepsy Brain and Mind Congress that will be organized next month in Brno. Epilepsy and music, epilepsy and psychosocial outcome, depression and meditation and so on. So please come. Thank you for your attention.